And last but not least, Phillip, with his unique classification of distal ulnar fracture.
Thank you, Andrew. Is anybody still awake after all of that? I've got a comment to make on scaphoid fractures and vascularized grafts. In 2000 at our Sun City Congress, Tim Herbert was our invited speaker, and he was asked whether he does vascularized bone grafts for scaphoid non-unions and fractures, and he says in 100% of patients I do a vascularized bone graft. He says after the operation I let down the tourniquet and the blood just flows into the non-union site. So I think I do 100% of vascularized grafts for all scaphoid fractures. Now, these are my disclosures. They're not relevant to this talk. So this talk actually is a vast topic to discuss the whole distal radial ulnar joint and its articulation. So I'm going to try and keep it down to about 45 to 50 minutes, if you're going to bear with me with that. More seriously, what I'm going to do is I'm really just going to go through 3 topics related to this thing. I'm not going to give a whole dialogue about it because it is a big subject. So I'm going to discuss some aspects of the anatomy that are important. I'm going to discuss the importance of the ulnar variance and some treatment for this, and then just give you some idea of the classification of distal ulnar fractures. So the distal ulnar plays a very important role in the stability and the kinematics of the wrist, and this would not be considered ideal treatment in this day and age. And the important components are the distal radial ulnar joint, the triangular fibrocartilage complex, and the ulnar collateral and the ulnar triquetral ligaments, with the continuation of the ECU fascia as forming part of this. It also plays a vital role in the maintenance of the normal wrist kinematics, apart from its role in prosupination, for which it's essential. And prosupination are not possible at all with a completely dislocated ulnar head. The distal radial ulnar joint is formed by the distal ulnar articulation with the sigmoid notch of the radius. The articulation is 75% covered with cartilage. It forms the attachment of the triangular fibrocartilage on both sides, and it has a groove in it in which the ECU tendon runs. It's a diarthral trochoid joint, they say, and it's relatively unstable, but it's reinforced by the articular disc of the TFC, by the radio-ulnar ligament, which is coming around here, and by the ulnar carpal ligament, which goes down there, and then on the top of all of this, the ECU sheath is a very important stabilizer. The ability to prone supinate are dependent entirely on the maintenance of the articulation between the distal ulnar and the sigmoid notch of the radius. And this is the key to what you have to achieve in terms of distal radial fractures and distal ulnar. This articulation must be congruent. If the patient has an ulnar positive variance, normally you check the other side. They may have different shapes to the fossa. It may be very oblique, it may be short, it may be oblique the other way, but the patient has another side for you to see what they're doing, and this is the key to good outcomes with the wrist there. So changes in the relative length of the radius and the ulnar lead to a change in the ulnar variance, and an ulnar positive variance implies that the ulnar is relatively longer than the radius. But remember, it's relatively longer to that patient's radius and not just purely a measurement. It must be checked compared to the other side. And it's most commonly caused by a malunited distal radial fracture. So how do we treat ulnar variance? If we do have a positive ulnar variance, the treatment is by prevention of anatomical reduction of a distal radial ulnar joint. And care must be taken. A lot of people say, I get very good results treating patients just with K-wires in the distal radius, and I don't need to do volar plates, and I don't need to check it. But you must be certain that the radius is corrected in terms of its length, and it mustn't be allowed to collapse down. So if you are going to put K-wires in, those K-wires must be divergent to contain the length, to stop the shortening, relative shortening of the ulnar later. You can do a radial lengthening osteotomy, and this is only really indicated if there's a combination of shortening and dorsal tilt of the patient, and you do a 3-dimensional trapezoidal graft. But far easier than doing that is to shorten the ulnar to make the ulnar relatively the same length as the radius. The ulnar shortening osteotomy is a far less complicated operation, much more easy to achieve, and far less complications of it. So this is a patient that has a malunion of the distal radius. I haven't got the lateral view here, but you can see in the CT scan the articular surfaces have been reasonably well aligned. However, there's displacement of the ulnar styloid and there's shortening of the radius with about a 6 or 7 millimeter ulnar positive variance. And this patient I treated with the ulnar shortening osteotomy. It's a long plate, but the new shortening osteotomy plates all have guided osteotomy sites there. And I think this is very important, so that you place the jig on the patient, you do an oblique osteotomy, whatever length you need to choose, between 2 and 8 millimeters you can achieve. And one of the key things is that you must constantly irrigate while you are sawing the thing. In fact, you should use the saw with a pool of cold saline in there, because getting the heat and burning the tissue can lead to non-union. If you're doing an osteotomy to correct a problem and you end up with a non-union, that's a disaster. So keep it very well lubricated with the saw and very, very cool. If we look at salvage, now if we can't, let's say we can't do an ulnar shortening osteotomy and the patient's got incongruity or they've got what do we do to salvage the prosupination in a patient in which we can't achieve fixation? And there are many historically advocated procedures. The old DRUJ procedure, the Bowers hemi-resection or interpositional arthroplasty, the Watson supposed matched resection, and the old Suave Kapanji technique. But these are all should be hit with a large black star, because none of them are good at all, because all of them end up with an ulnar impaction. And what happens is, if you start off with a DRUJ, you do it there, it's shortened, you shorten it further, it impacts here, it shortens there, it impacts further, and they end up with pain and not an improvement in their prosupination. So these are pretty historical. This is a dramatic X-ray, but you really need to consider, if you have a problem, you need to consider a replacement of the distal ulna. And even if there's been significant shortening, this is a patient who had a DRUJ procedure and was very unhappy with it. There's got a little shaft that you can add on there, and these patients do very well with the prosthesis. If the ulnar styloid is still attached, you can do a hemiprosthesis. These days is available. I don't have an X-ray. I did have one, but it seems to not come up in this talk. And this is a very good option for the patient. And remember, if this fails, then you can still consider then doing an excision arthroplasty. Briefly going to go on to fractures now, and really I'm going to be another 4 minutes or so. So fractures of the distal ulna, the third of the ulna, are what I consider the poor cousin of the distal radius, and they're often overlooked, and they can often be very important. And I know it's every time we go there, oh, it's the ulna, don't worry, it's a nightstick injury, don't worry, it'll be fine, but it can cause a lot of trouble, and there's a few tips that you need to look at. So, for example, this fracture, everybody knows that needs to be treated. It's going to end up with a problem, and it's got a good union site. This fracture, on the other hand, it looks dramatic, but it's stable because it's a transverse fracture which is impacted from a direct blow. But any time you see an oblique fracture like that, applies that there's been a rotational instability to the fracture, and there's been a pronation or supination force, and this fracture will shorten if it's not treated. There's many classifications. Probably the only one of significance is the AO classification. And really, all that's important, and I'm going to know, they're fractures of the ulnar styloid itself, they're fractures of the base of the ulnar styloid, and then there's shaft fractures of varying complexity. The shaft fractures, as I said, are either stable or unstable. The distal radial ulnar joint fractures, or the fractures themselves, you need to look and you need to assess, is there ulnar positive variance, is there negative ulnar variance, and is the ulnar head dislocated? Because these will dictate your treatment as to what you need to do. And you need to be sure that after your treatment of this, that the TFC is well reduced and that the ulnar head is stable and not dislocating. And you must check the ulnar head in pronation and in supination on the X-ray. And if there's any instability, you need to then do a soft tissue repair as well. Ulnar styloid fractures at the base of the ulnar styloid are different fractures, and I'll come on to those now. So if we look at the ulnar styloid fractures, they can be displaced or undisplaced. And this is really the absolute key to distal radial fracture treatment. If your distal radial fracture, after you've finished fixing the radius, the ulnar styloid is still displaced, it's not 100% anatomically reduced, that patient has an incongruous triangular fibrocartilage. They have to have, because the TFC has pulled off on the radius and has shortened then. If you have that situation, you need to look at your reduction of your fracture, and if the fracture is well reduced, then you need to fix the TFC at the time of the surgery. And again, you need to assess the stability, dorsal and volar, of the distal ulna. Basal styloid fractures are most commonly related to avulsion fractures rather than direct blows, and these need to be treated with a screw fixation or with a tension band wire. So if the basal styloid fracture is more than 3 millimeters displaced medially, you must check for a TFC injury. And this patient had a TFC injury because the triangular fibrocartilage is attached to that thing, and if the radius is shortened, the TFC must have pulled dorsally and radially in order to achieve that displacement of the styloid. Fractures of the base of the ulnar styloid, as I said, are unstable avulsion injuries and must be fixed with a compression screw. And these are fractures which occur truly at the base of the styloid. The gold standard is the tension band wire. It's done through a small, simple ulnar approach, but you can use a lag screw to do this. It's often a good thing, particularly with cannulated screws. But sometimes we can get a bit carried away with fixation. And if we say we're going to do minimal fixation, it must be minimal fixation. And these are all minimally invasive plates and K-wires and bends, but there's about 500 of them in the distal radius. I think it's very difficult for that bone to unite. If we have ulnar shaft fractures, these are treated as, of the distal third of the ulnar, these are treated as shaft fractures. And remember, the most important is the short oblique fracture, which is almost like a Galeazzi type of injury, except there's no fracture of the radius, but there must be an interosseous membrane ligament instability here, and this must be treated with a plate and screws. The comminuted ulnar styloid fractures are treated on their merits. Pediatric fractures, obviously we do more conservative treatment with pediatric fractures, and these will reduce sufficiently almost always with the reduction of the radial fracture. But if necessary and there's any displacement after reduction of the radius, then a simple longitudinal K-wire is perfectly sufficient for these fractures. So in conclusion, please don't ignore the poor cousin of the radius, because the distal ulnar with the TFC plays a key role in the maintenance of wrist kinematics and is essential for prone supination. And careful assessment of the distal ulnar, particularly the ulnar styloid and the TFC, can prevent significant later morbidity and avoid the need for reconstructive or salvage procedures to regain prone supination. Thank you for your attention.
Phillip and Grant, thanks very much.